Welcome everyone to the University of Maryland School of Public Health panel discussion on emergency preparedness. This panel discussion will be recorded. I'm Giberson Roth, the Vice President of the School of Public Health Alumni Network and a graduate of the Family Science Bachelor's Degree Program, class of 2017. I'm joined by our board president, Dr. Alyssa Todaro Brooks, a graduate of the Behavioral and Community Health Doctoral Program, class of 2015. Also with us this evening are Dr. Matthew Guidry, a 1975 PhD graduate in recreation, Ms. Dina Gregory Fisher, a 1997 Masters of Public Health graduate in kinesiology, and Ms. Francine Baker, a 2017 Bachelor of Science graduate in Public Health Science, all of whom are members of the Alumni Network Board. This event was organized by the University of Maryland School of Public Health Alumni Network in partnership with the School of Public Health and is open to all UMD alumni, current students, and friends of SPH. The University of Maryland School of Public Health Alumni Network is dedicated to providing and partnering on virtual programs similar to today's experience. We hope that you will continue to connect with us virtually and eventually in person. The UMD School of Public Health Alumni Network works to promote and support the school, encourage academic and professional excellence, and facilitate career development for both current students and graduates, while fostering and strengthening a lasting relationship between the school and its alumni. We encourage you to support your School of Public Health Alumni Network by joining today by visiting our website, sph.umd.edu/sph-alumni-network. Your membership supports diverse programs and events curated just for our alumni community. Today's conversation will be moderated by our fearless School of Public Health Dean, Dr. Boris Lushniak, who will introduce and conduct a question and answer session with 3 cross-sector public health experts who are active in strategic emergency planning, research, and preparedness communications. We encourage you to send your questions to us via the chat or during the Q&A session, use the raise your hand function and be called on to ask your question on camera. And now I will turn over our discussion to our Dean and Moderator, Dr. Boris Lushniak.
Thank you so much, Jameson, and thank you for all of you who are on at this hour. It's now 6:33 Eastern time, and I know we're in the midst of probably dinner time for several of you. So if you're eating, that's great. We're glad that we're part of your sort of program while you provide nutrition to your body. For those of you on different time zones, whatever you're doing, we are just so glad that you've joined us. And let me put in this plug as the Dean of the School of Public Health at the University of Maryland for the incredible work that people have put into organizing this event. And in particular, the volunteerism of not just the members of the Alumni Network, former classmates of yours perhaps, but also in particular the panelists who are here with us tonight to share some of their experiences, some of their ideas, and to really view all this from a cross-sector approach, right? We're all very different people, as you know, in public health. If you look at the degree paths that we offer at the School of Public Health at the University of Maryland, at the undergraduate level, the concentrations at the master's level, the type of doctorates that we have, public health is kind of all-encompassing. It's a full spectrum. And even when it comes to emergency preparedness, we view it from the world of our own levels of expertise. And we have some incredibly gifted people here tonight as your panelists. Something like this does not function well if it's strictly a group of talking heads talking to you. But in essence, what I want to emphasize is this is a discussion over the course of the next hour with you, which is at some point, even now, begin putting in your questions. We'll organize ourselves so that you get answers to things that may be intriguing to you about emergency preparedness. Now notice that we're kind of taking an all hazards approach this evening, but it would be remiss of me not to reflect on what we all experience from very much different angles in terms of a commemoration, right? This past weekend of 20 years ago, the tragic events associated with September 11th at the World Trade Center, at Shanksville, and at the Pentagon, and the repercussions that led to worldwide, right? The global repercussions of that act itself, followed by, in essence, the dilemmas of how you react to that, right? What's the public health reaction initially to all this? Ultimately becomes a diplomatic, ultimately it's a war scenario, right? All that led from terrible things that happened 20 years ago this past Saturday. We're not here necessarily to look back, right? This isn't a commemoration. Notice that even in the title, we're not speaking of 9/11 as part of our discussion, although many of us have perspectives about that. I myself at the time was a Commissioned Corps officer in the United States Public Health Service stationed with the Centers for Disease Control and Prevention at the National Institute for Occupational Safety and Health in Cincinnati, Ohio. And the minute that started happening, the unfolding of the events that many of us had lived through while watching a TV screen, I kind of knew that within a few days, our team would be at the World Trade Center. And that in fact unfolded. That led to me personally being affected by all these events very directly. We went there to do public health good. That's a key feature of what the response was. Ultimately, at the World Trade Center site, ground zero, the job really was about occupational and environmental exposures in the midst of that incredible tragedy. And it really changed a career path for me. There's a Boris Lushniak pre 9/11 and there's a Boris Lushniak post 9/11. And the two really sort of take very different paths. Many of you perhaps can even think about that. Some of you may not even have been born at that event, right? Others can look at, well, how the world changed, perhaps directly or indirectly as of that event. But certainly that event did touch something in us about the concept of vulnerability and all hazards vulnerability. And the sense is that we, from a public health perspective, need to be prepared. And therefore, this whole panel discussion today about emergency preparedness. And whether it's a terrorist event, let's not forget that a few weeks after the 9/11 tragedy, what happened? We had anthrax in letters sent to locations in Florida, in New York City, in Washington, D.C. It was a 1-2 punch back in 2001. Again, personally, I returned home after my deployment to the World Trade Center, was home for a few days, back in Cincinnati, resting up, trying to process everything I had seen at the World Trade Center site when we were sent off again, this time to Washington, D.C., to deal with the anthrax attacks. Subsequent to that, we had many other things that affected our nation, right? And the biggies, there's so many there, but we had natural disasters, right, that we had to prepare for. The sort of the calamity of Hurricane Katrina. Yeah, I, as a Public Health Commission Corps officer, was a responder there, working both in Baton Rouge and later on in San Antonio, dealing with, in essence, what were internally displaced people leaving New Orleans and the public health ramifications of that. 2009, 2010, we had H1N1 as a pandemic that brought the P word to our vocabulary in this generation, a very different pandemic than what we're experiencing over the course of the last year and a half, but that refocused on preparedness from some looking at the world of infectious diseases. Subsequent to that, we had Ebola as a biggie. Not necessarily directly affecting the United States, but certainly indirectly affecting our psyche, but affecting Western Africa with over 25,000 people infected with this terrible virus, roughly 50% of them dying from this virus, and a worldwide approach to trying to squash a epidemic, a regional epidemic at that time. And then finally, certainly, we look at not just the pandemic of SARS-CoV-2, the virus that causes COVID-19 in this past year and a half, but the terms that we've been using at the School of Public Health are the syndemics, right? Emergency preparedness, not just for infectious disease, but in essence, emergency preparedness to a large extent of what's going on in our society, right? Once again, multiple issues coming to the forefront, right? We have gun violence, we have racism, we have political upheaval, we have climate change. Define emergencies in very different ways. Part of the public health approach on this is how do we get better as we have to deal with these various calamities that affect us as humankind. Today we have three panelists, and I'll start first with Dr. Dylan Roby, who is an associate professor in our health policy and management program within our Department of Health Policy and Management at the School of Public Health. Dylan is a well-known faculty member who's doing incredible things at the School of Public Health and kind of views the world a little bit differently than other people may, right? His whole approach to things looks at, right, economic burdens. It looks at, you know, the world of payment plans. It looks at the world of looking at how we deal with emergencies, but strictly from an angle that may be very insightful in terms of how we look at the world of emergencies. Ashley Henyan is a graduate of ours, 2002. She's now the Regional Communications Director at the American Red Cross in Washington, D.C. for the Washington, D.C., Baltimore, and Wilmington, Delaware, and Eastern Shore area. And looking at that organization, certainly the American Red Cross plays a critical role in terms of both preparedness as well as response to various emergencies that exist out there. And then finally is Scott Giberson. By training, he's a pharmacist, has a master's in public health, has a doctorate in science, and he is currently, and recently this weekend, was given a promotion, previously the executive director, but now the president of corporate, or executive director of corporate affairs, now the president of AMI Expeditionary Healthcare, which in essence is doing emergency response, not only within the United States, but at the same time, emergency response worldwide. Scott is a friend of mine. He and I served together in uniform as Commissioned Corps officers of the United States Public Health Service. And to a large extent, we worked together probably over the course of the last decade very closely. When I was the acting U.S. Surgeon General, Scott was the acting Deputy U.S. Surgeon General. He was a leader and a forceful responder in the midst of the Ebola outbreak, led our first U.S. Public Health Service team to Liberia to be a responder and to be an organizer of that event. But in terms of his background, has done incredible things while serving in uniform, and now as a retired Rear Admiral of the Public Health Service continues to do that in the private sector. So I welcome all three of you to this incredible panel evening for us tonight. What we're going to do time-wise is we're now at the sense of us beginning a discussion. And within that beginning of this discussion, I'm going to ask specific questions of individuals. We'll have sort of that group think of answers to some of these questions. But in the meantime, I can't stress enough that if you have questions, please begin posting them in the chat, and we'll be monitoring those questions as we go on. So I'm going to begin initially with Dylan, with your unique perspective, right? So you're a subject matter expert, as I sort of defined you very generally, right? And you can go into specifics of how, Dylan, you view the world. But with respect to all of us on this panel, all the panelists were active in the public health field, some during, some shortly after 9/11. How have disaster preparedness recommendations, research and communications changed with regards to your sector over the past 2 decades? Right? When you view the world from your angle, and the other panelists be ready to view this, answer this question as well, as you look at 2 decades since 9/11, if we take that as the beginning of a major change in our country, what's changed in terms of preparedness recommendations, research, communications? Dylan.
So I think, thank you, Dean Lushniak, for hosting this today and for the provocative question. So I think I do look at this from a unique perspective in that, I was in the health policy world in DC around 9/11, working at GW right down the street from the State Department. And, what struck me about there has been a lot of change in the past 2 decades. The immediate response to 9/11 from a policy perspective did not focus on healthcare very much. It focused very much on Homeland Security. The Patriot Act quickly passed, and there was this effort to do intergovernmental integration to share intelligence and make sure things didn't happen again. But there wasn't really a response to the mental health, potential, first responder illnesses that we're now seeing. And so you didn't really see some push to create better public health funding, integration, coordination, directly in response to 9/11. That being said, I do think since 9/11 in the past 2 decades, the ability to disseminate recommendations has changed quite drastically. If you think about the think tank policy briefs and policy memos and the ability for advocacy organizations and interest groups to put out their opinions and recommendations and disseminate those freely and get them in the face of legislators at the state, local, and federal level has changed a lot because of the internet, because of how we interact with information now. And so where we used to see pre 9/11, very much a focus on the core think tanks in DC putting out thought pieces that were provocative to legislators and governmental officials, and everything was very much done on paper and meetings where you're handing a policy brief to someone and having a ledge affairs meeting. Now we've seen like this ability for the population to see what the recommendations look like and get involved in providing feedback to that preparedness. So I think the 9/11 didn't trigger some, revolution in terms of integrating healthcare better with disaster response. But I do think our ability to do that as advocates or, policy experts has increased in the past 2 decades because of the fact that we can now put things out that are listened to if you pitch it the right way and if you frame it the right way by folks in power who can actually influence the process.
Great, thanks, Dylan. Ashley, from your perspective, right? 20 years, what's changed from your perspective and your leadership role within the American Red Cross?
Well, I think the way that we access information and the speed at which we can would have been very helpful when 9/11 occurred. I was actually at the University of Maryland. I was a junior in college and remember trying to get over to my boyfriend's house who lived in Rockville. And it was this there was no way to find out if anybody was okay or where they were or how we were going to connect. Not even people had cell phones then. It was not common. So one of the tools the Red Cross has now is called it's Safe and Well website that you can mark yourself as safe. You can mark that you're searching for a loved one. And I think back as to how helpful that would be in a situation like 9/11. And that's definitely one of the way things have changed. The other thing that I think about is really the use of social media and not that it's a way to necessarily disseminate information, but at the Red Cross, we are often able to use it in our regional channels to find out where people are that actually need help. And then we can send help and connect with the right organizations to get them help. So that type of the way to access information very quickly at your fingertips, I think is what has changed the most.
Great. And Scott, your perspective. Most of that time period in the 20 years, you were an officer in the United States Public Health Service Commission Corps. You were part of the U.S. government, and certainly in those later years, a leader amongst those, right? Those individuals. I want you to reflect not only on that changes in U.S. government approaches, but also in the private sector. What are you finding there that's different? Thanks, Scott.
Sure, no problem, Boris. So obviously it has changed, in my opinion, drastically in the last 20 years. I think that the two, mega events, 9/11 and COVID, have changed the way we do a lot of things. And it's two things I see. One is communication freeway, and second is globalization. Everything affects everybody, whether it's in a different country in a different part of the world or just the United States or where it's happening, if it has the potential. The second thing is I think we're able to differentiate on the complexities of things when it's an overt disaster, and I like disaster psychology. When you have an overt disaster like we saw with And it was a perfect example of, you gave, Boris, of 9/11, right? Overt, buildings get hit, everybody responds, patriotism, immediate recovery starts. Versus a month later, we had anthrax, which I was deployed in the post office that tested positive for anthrax. At the time, I was a junior officer as well. And, the complexities of the insidious progression of the bioterrorism side and the anthrax was much more difficult to deal with as a responder versus the trade center. So I think we're learning about, over the last 20 years, about the different complexities. The change in the rest of the system is the fact that now we have this communication freeway to deal with. And I think sometimes, like an overt disaster, hurricane, tornado, World Trade Center, it's a blessing. In some cases, as you're seeing now with COVID, I go to argue about some of the benefits of some of this communication freeway, and it's complexified a lot of the things we do and the recommendations we make. And, I think we're learning how to deal with that. And every disaster is a little bit different now. And so now we have to consider every piece of it, the geopolitical, the ethical, the regulatory, the social aspects of it, because so many people have so much information, whether it's misinformation or not. So I think that's the biggest difference in the last 20 years.
Great, thank you, Scott. Ashley, I want to pose this next question to you first. And we talk about, various levels and types of disasters, right? You have your natural disasters, you have in the case of 9/11, anthrax, man-made, man-caused disasters. And they obviously have far-reaching public health implications across the affected populations. And we've taken this all hazards approach. I mean, this is going to be an all hazards type answer, right? Realizing that recommendations or responses are very specific, right? What's recommended for COVID is not necessarily applicable to what was recommended for Ebola, what was recommended in the anthrax time period, or even the post 9/11 time period. But are there practices from your perspective, right? Practices or recommendations that are communicated as a rule? When it comes to communication, what's the key message to be getting out in the midst of a disaster?
Yeah, it's a great question, right? And I think from a very broad perspective, it's important for everyone to remember that it takes a village to respond in any type of emergency, right? There's never one organization that can handle that themselves. And so I think keeping that mindset, whether you're in the field or someone that might be looking for help, and understanding that there's a lot of different pieces that always have to come together. But when it comes to preparing yourself and your family, it sounds very simple, but we like to use just the very three-part message, which is get a kit, make a plan, and stay informed. Every single person should have that emergency kit in their house with at least 3 days worth of food and water, an extra month's worth of medications. I always recommend that people take their files and put them on a thumb drive and just have that with them in their kit so that they have access to their insurance documents and their passport. And then, if you've ever been in an emergency situation where you've lost power for a very long time, it is essential to have two things. And that is cash on you and gas in the car already. And so that's something that people can think about as they start to prepare for the unexpected. The other thing that I think is very important to think about is how to mentally prepare for a situation that we don't really have any control over, or that might be scary. At the Red Cross, we teach something to children ages 3rd through 5th grade, and it's called the Pillowcase Project. And they actually go through a mental preparation meditation to learn how to control your own breathing, to learn how to calm yourself down if for some reason you were trapped in your home and it was on fire, or if there was an earthquake. And I think that technique also applies to adults, and it's something that we can learn from, to take a moment out of the day and just learn how to teach yourself to be mentally prepared to deal with the unexpected, to deal with something that might be scary. Aside from that, the one thing that never goes away is the need for blood. So I can't, not answer this question without touching on that, because it's something that it's too late if you wait until you do need blood to put it back in the shelves. There's a shelf life for blood every 42 days, depending on the product, but that's kind of the average for red cells. It goes bad. It's the blood on the shelves that everybody reaches for, the doctors in the emergency room, when there is a large scale event. And so that's why it's important to kind of get the word out, and that everyone that's eligible does go out and donate blood, and they do so regularly to keep that supply healthy.
Great, thank you so much from that emergency preparedness aspect. Scott, the same question to you in terms of what needs to be communicated. But the angle I'm going to throw at you is, from a responder perspective, right? What does the public need to know what's going on from a response perspective?
Well, and that's careful how you have to explain that to the public. But I think transparency is really good for the public. I think it's a little bit challenging, more so now than it used to be. I think the science was a stabilizer to some degree in the past, and now it's a little bit in question. So, it is challenging from a response standpoint. I think another thing that's been changing is the need for psychological first aid. I think, we as responders have to consider that in everything we do. And we have the typical, trauma care, triage, those kinds of things, depending on what the situation and what the event, but adding different layers in for communications and psychological first aid will be really important moving forward.
Great, thank you. And Dylan, I'm going to hit you with the hardest part of the question, right? I'm going to put the umbrella on you of being the policy guy, right? So put this from the frame of mind, and mind you, to the audience, none of these questions were pre-rehearsed. I mean, the specifics. Yeah, the panelists had the general sense of a question there. So I'm really sort of throwing curveballs at these people, but Dr. Roby's a really smart guy. So from a policy perspective, where have things worked and not worked? And maybe you can use COVID-19 as an example in terms of, what do people need to know, right?
Yeah, I mean, I think one core recommendation around disaster preparedness is often related to coordination between all the different entities that need to be involved. And if you think about the federal, state, and local level, those are 3 levels of government that we rely on. However, we need everybody to be talking to each other among those 3 levels of government. In addition, each county has a mental health department and a public health department. Each state has often a mental and substance use disorder department and a healthcare services department. And the federal government has FEMA involved, CDC involved, 8 other offices in HHS involved, public health service. And so unfortunately, I can't recall a disaster where all of those things worked well. And maybe Dean Lushniak has an example from his work when he was Surgeon General, because, he knew what he was doing.
When I was the acting Surgeon General, things always worked perfectly, right, Scott?
Exactly.
Oh, sure.
So thinking of COVID, like the fact that you had CDC issuing recommendations about masking, testing, how to define a case, and those recommendations were often not actionable for the counties that didn't have tests and didn't have the ability to get PPE for the people running the test site. So like you can envision that the bureaucratic problems that we are used to in our governmental system are very much exacerbated if there are gaps in that approach during a pandemic or a disaster. So I think, as a rule, we should be coordinating across all the different governmental entities and agencies that need to be involved. But often we are caught very flat-footed when responding at multiple levels, and the silos that are created at the local, state, and federal level within the actual jurisdiction and then up and down those levels are often a problem that we can't really easily solve without a lot of dedicated effort.
Great, thank you. Any other comments on this topic from Ashley or Scott? Anything to add? No, we're fine. Okay, let's move ahead. Scott, it's almost a sense of lexicon. I kind of want to sort of almost back up to the beginning. We talk about definitions, we talk about parameters, natural disasters, man-made events, a public health disaster emergency. What does our audience need to know about, kind of the lexicon that's used out there and sort of the parameters that are used?
Yeah, sure. I mean, let me differentiate a little bit first and say that, when most people think of a major emergency, they're likely referring to a presidentially declared one, right? So you have a certain Title 42, and the Stafford Act, which you may or may not have heard of, people know. And when it's a major event, it could be a public health emergency as well, but it causes damage and, severity that a governor of a state or a leader of a tribe will ask FEMA through the process of the regional, coordination to declare a presidentially declared disaster, a PDD, right? This unlocks the resources and systems and mechanisms at the disposal of the president and others. So when you talk about a public health emergency, quite different. First of all, it's in terms of the declaration. First and foremost, it doesn't have to be declared by a president, and it doesn't have to be put forth by a governor or a tribal leader. It can be the Secretary of Health and Human Services, and Boris and I are very familiar with this. And we can say it's Section 319 of the Public Health Service Act. And no, I don't study PHS acts, but I happen to know this one really well because 27 years of looking at the act and different things, which one it is and what section. So, the public health emergency, the PHE, can be declared by the Secretary of Health and Human Services. How does he or she determine that? And it would be similar to a presidentially declared disaster, meaning she consults or he consults with public health officials, and maybe even somebody like an acting Surgeon General like Admiral Lushniak, and says, is the disease or a disorder or natural event, does it present a public health challenge sufficient enough to declare or warrant the declaration of an emergency? It could be a significant outbreak in disease. It can be as a result of or secondary to an event. So, many of the public health emergencies in the last 2 decades have been secondary to a hurricane or flooding, even wildfires. So they consider the extent of the disaster or the impact, the magnitude, and the types of resources that might be needed. So much like the president, when the Secretary of Health and Human Services would declare a public health emergency, you'll see unlocked resources and abilities to tap into different things that are normally harder to tap into, whether it be waivers for Medicaid, Medicare, whether it's how the prescriptions are dispensed, or some of the regulatory pieces are sort of waived. And so all those things are at the disposal of the Secretary, including, and we're familiar with, the deployment of different assets like the U.S. Public Health Service Commission Corps. So, all those things are part of it. Some examples of, now you guys, we talk about the hurricanes and the COVID and the Ebola and all that stuff. I mean, if you think, there's a lot of public health emergencies that most people may not even know. And I know Boris mentioned one already, H1N1. I think he said it was 2009. Zika outbreaks, wildfire, the secondary to the wildfires were public health emergencies, smaller flooding areas in the Pacific Northwest. And here's a good one for everybody to know: the public health emergency has been declared and has been continued for the opioid crisis in America. And so it can be continually renewed in 90-day periods. And so for years, the opioid crisis has been renewed, and it'll be renewed again. So, those types of things that we deal with in our world of public health, maybe not as visible as some of the other things to people around the United States or the globe, but happens all the time. And the Secretary can determine that. And sort of that sums up some of the differences between the presidentially declared one and the public health emergency, as to what might entail those resources and what triggers it.
Great, thank you. Ashley, does this all play a role in terms of how the Red Cross reacts to emergencies, these types of sort of designations?
Well, I think the more widespread and the more varied certain public health emergencies might be, it will inevitably affect the ability for the Red Cross to collect blood. And so, I hear things like Scott mentioned about the Zika virus, and when something like that becomes a problem, the guidelines change, and people's eligibility to be able to give blood might change. And so now all of a sudden your donor population is decreasing. So that's kind of, where I see it. But if you also think more very localized, but when you think about the number of home fires that we have in our society, to me, that's someone's very own personal public health emergency, especially when it happens to a family that might not be able to cover an unexpected expense of maybe even $400 or more. And so all of a sudden, if someone might be on an assistive medical device, if they depend on eyeglasses or cane or walker or wheelchair, and they experience a home fire right there, that's their own personal crisis, right? And that's happening about every 8 minutes across the country, which you add that up, and it certainly constitutes a public health crisis, in my opinion. Just another way to kind of look at it. Yeah.
Great. Good. I'm going to beckon the audience. Yet again, I'm getting a few questions in directly to me. You can either write to everyone or to me or to Jennifer with the questions. So we have a few questions that are coming on. We will get to them, which now we introduce at this point. It's 7:06. We promise a closure at 7:30. We're into the lightning round. So now it's going to be one question per person. And this makes it really exciting. And we're going to start off with Dylan, because Dylan, what I want to know is, what was Dylan like before COVID? And what's Dylan like after COVID in terms of, you describe it, your research, your communications, your work situation, right? Tell me a little bit about Dylan and what you've been working on, and has the COVID-19 or perhaps the syndemics changed your approach to things?
I mean, for the past 25 years, most of my work has focused on health insurance and access to care. I think what COVID has done is create this policy emergency in a way that could actually be addressed by the health insurance system partially. Whereas if you go back to 2001, when we have a slight economic downturn related to 9/11, go back to 2008, when we had, the mortgage crisis and an economic downturn, the emergency to deal with tended to be people who are uninsured and didn't have access to care. The ACA came out of the 2008, 2009 economic downturn in a way. It created this policy opportunity to pass comprehensive legislation to kind of shore up the health insurance system. And I think in the context of COVID, we see that as a baseline for insurance coverage. And so when the federal government is making decisions, as Scott mentioned, related to Medicaid waivers, it impacts a far more larger number of people because more people are on Medicaid now. So if they decide to waive cost sharing for certain things, or to increase federal matching funds going to the states through legislation because of the COVID pandemic, they can immediately get resources to a certain place. We also saw that happen on the private insurance side, where HHS basically said, well, COVID testing, screening, and treatment is a required benefit, and it should be delivered at no cost. And they now have the ability, because of the Affordable Care Act, to regulate benefits in a way that requires insurance companies to pay for those things and do it at no cost, especially on the preventive side. And so I think the ACA in 2008, where the crisis was an economic one, it created this opportunity for us to have a more comprehensive, stable health insurance system that we can now kind of pull policy levers to address new disasters. And in this case, the COVID pandemic is a good example of that. And, a lot of my work has been in trying to find problems for legislators to potentially solve. And I think in the case of health insurance and access, we have done a better job in this pandemic, at least, of ensuring that people have access to timely testing, and that providers are incentivized to do that testing because they're actually getting paid for it. And it's not completely run through county governments, which are already overwhelmed. And a lot of that is made possible by payments coming from the health insurance system.
Great. Thank you so much, Dylan. Lightning round question. Ashley, you're up. Okay. Disaster strikes. What's the first steps, right? When people want to help, and we've seen this all the time, right? We are, and again, you see the best of humankind in the disaster, and you sometimes see the worst of it, but people oftentimes want to help. What do you think from your perspective, right? What are the first steps people, for those who want to help others, should be doing, right? And specifically, are there organizations? I imagine the American Red Cross is on that list that we should be supporting in times of emergencies. So, Ashley.
Well, I mean, yes, right. I'm not going to say no to that. The Red Cross depends on donations from the generous public to actually perform all of their services and provide all of their services. But I think, we take a step back first and think about, waiting for the disaster to strike and then thinking about what you're going to do. It might be too late at that point. So even thinking about being prepared in terms of what organizations you want to support ahead of time, because they need the resources, they need the volunteers, they need the staff to be able to help in that time. And that takes a little bit of preparedness on their end. So thinking a little bit ahead of time about some trusted organizations, charitytracker.com, I think, is the site where you can actually kind of see how they are rated, and find an organization that you would like to volunteer with, that you would like to donate with. One thing I think is super important to know, and this happens inevitably after every disaster that we see at the Red Cross, is that people like to clean out their closet or clean out their basement or clean out their garage and donate stuff. Well, donating stuff to an organization that helps people that have no home because it was just flooded or leveled by a tornado, that stuff's not going to help them, right? They have no home to even put this stuff in. So when you're making decisions about how you want to help after a disaster does strike, whether it's locally or large scale, you definitely want to think about making a financial donation as opposed to material goods, because that really will go the longest way to help people.
Great, thank you, Ashley. Scott, I Ashley touched a little bit about this, but I want you to kind of look at it from that responders preparedness perspective. And it's really, what's regular people, right? So people like you and me and Ashley and Dylan and many of our listeners here today, what do we do in our own home setting, in our community setting, to kind of get us prepared for these emergencies? In the Commission Corps, we always had the go kit, right? So as officers, we were told, be packed, ready to go. That was a sense of preparedness. We had training, right, that got us into this mode. Now, in the general population, from your experience level, what is it that we need to be doing? You're on the mute, Scott.
I'm off the mute. All right. So yeah, good question. I actually looked up some data, and I wanted to see what FEMA statistics say, and they say that only 39% of Americans have any sort of idea what to do with, a disaster, no disaster planning, no kits. I actually think it's pretty positive that at least 39% had something, but we'll try to improve that. I know Ashley said some really good things earlier about, sort of personal home kind of preparedness and things like that. And I look at it from sort of that deployment kind of readiness piece. So I think 72 hours, obviously, but I also think that in a disaster or in a crisis, you don't think as clearly as you might hope to. So, having the very most rudimentary things or pragmatic things stuck on your refrigerator or stuck in your cell phone. So in my cell phone right now, I have the list app, and it just lists things, and I have emergency phone numbers, a couple of websites, and some links to other places that I can connect. And so for me, communication is number one, and that's a little bit of a officer deployment kind of thing. So establish communications, stay connected, whatever it takes for you to communicate with whomever you need to communicate with. That's number one in my book. That's beyond personal safety first. I mean, consider your immediate safety needs, make sure you're safe, make sure you know where to go, what to do for some of the disasters. Also, I would say, be aware of what the disasters are in your area. If you've moved to a new area, or if you're not familiar with those kinds of things, if you're living in New Orleans, I wouldn't be concerned first with wildfires. I'd be concerned with flooding and, hurricanes, but there's just some common sense in that. And so make sure you have that to stay connected. And then, a disaster kit. We always have those. We preach about the go bag, but this is a little bit different for our homes. And I think 72 hours. I also teach the H2O method. I don't know if you do any of that, Ashley, but it was a long time ago when I was teaching H2O. It's still appropriate. So 2 H's, healthy and happy, meaning all your things that mean keep you alive, and then the things that take care of your mental health and social health, and then the O for operational stuff. And so candles, batteries, heat, all those kinds of things that you need, necessities to stay alive. So obviously, I could say the last thing would be practice. So I talked about staying connected, considering your immediate safety needs and where you live, making the disaster kit, and then practice. You don't really hear about people practicing these kinds of things, but at least bringing the topic up with your family and close and loved ones and maybe neighbors, just to say, hey, you guys know what we do in this situation. And I've done that. I lived in a cul-de-sac, and although I didn't want to seem too out of control with like disaster planning, I did talk to everybody, especially the heads of the households, and just to say, hey, what would you do, or what are you guys doing, or what community things do you do that are for community preparedness. So there's a lot of websites out there. One that I like to go to the most is ready.gov. And it's a government website, but it provides a lot of resources, probably much like the Red Cross. And you could find a lot from that. So if you have your smartphone, just have a shortcut, just tap it right on your cell phone and go to ready.gov. Will give you a lot of information.
Great.
Can I just add just real quick?
Absolutely, Ashley.
To don't forget your pets in that plan, right?
Oh, yeah.
Because
Right.
that's something also that pets have medication, they need food, they need a gallon of water a day as well. So you want to also to kind of consider that. And I'm sure that you can find more information on ready.gov for that as well.
Love
And,
it.
that was an amazing part of our response, when I was in the Commission Corps to Hurricane Katrina, was all of a sudden being hit with this incredibly, not only, the thousands of people who were displaced, but it was the whole effect on the pet population as well. So much so that, within the Commission Corps of the Public Health Service, we actually have veterinary officers that were put into this deployment role, right, as public health people, and oftentimes dealing with everything from cats, dogs to horses that were left behind, right? I mean, that's sort of an amazing component of, again, the full spectrum. We're going to go just briefly, and we're going to finish up later on in about 12 minutes with a closing question to all three panelists. But I'm getting some great questions from the audience. Many are being sent directly to me. And this dovetails to what Scott and Ashley had told us about preparedness. But, I'm going to hit Ashley with this, which is people with limited resources, right? Poor people in the world, right? They can't afford the extra cash, the food, on-hand preparation for things. Anything that the Red Cross is sort of involved with in terms of making sure that the issue of disparities and equity play a role in terms of preparedness?
Well, first of all, we're committed to making sure that anyone that needs a place to stay after a disaster has a safe place to stay. They have warm meals, they have water, they have health and mental health support from trained volunteers. That's really first and foremost as far as what the Red Cross wants to do.
Great, thank you. Another question that came in, and this is from Rebecca. I think she sent it to everybody, and it really brings up. I mentioned it when I sort of described the syndemics and sort of pending disasters, or disasters occurring before our very eye. Yes, comes with a certain amount of controversy. Is it real? Is it not? We certainly in the public health world have our opinions. Yes, I believe climate change is real. But how is this changing our approach? The question that Rebecca asks is, can you comment on the way disaster and emergency preparedness fields are talking about climate change, right? Have we begun that discussion or not? And how we as public health professionals can help the public understand that climate change really does pose a potential health emergency. Ashley, why don't you start, and anybody else who has an opinion or perspective on that?
It's crazy, and especially from a communications perspective, the frequency of more high intensity, large scale emergencies, there's no break anymore, right? It's not we have one and we go off and we respond and then we have time to kind of like relax and take a moment and get ready for the next one. It's one after another after another. 2,000 volunteers deployed just last week to help with Hurricane Ida, with wildfires, and it's continuing and it's ongoing. When it comes to telling that story, that Red Cross story in the media, for me and for my colleagues, we're trying to make sure we have the capacity of volunteers to participate in all these responses, and we're making sure that we have the financial backing, right, to fuel the mission. But what I'm seeing is you can become numb to it, right? There's almost like a numbing effect where you see this happening over and over. Just before this panel started, I got another email from our weather expert at the Red Cross, and there's another tropical storm, and I saw myself kind of just delete, and that's not something I should be doing, but it's something that happens when you're seeing it over and over and over again. So what we're doing is we're trying to really figure out how to be innovative in the way that we tell our story and share our message, and be on the forefront of letting people know that yes, the climate is changing globally, and we're seeing more frequent and larger disasters because of it.
Great. Dylan or Scott, any perspectives from you on the climate situation, either from a policy insurer perspective or from even the AMI or other perspectives? Dylan, anything from you?
I think from a policy perspective, it's tough because certain climate change symptoms are clearly climate related, and others people may not perceive it that way. So I think Californians, and I'm one of them, we've had droughts and wildfires for many years. And so the perception of the need for a policy response and the political will to get things done is stronger in that state than, in states like Maryland, where we might be hit with flooding in Ellicott City or something like that, and we don't perceive it as a climate change issue. And so the local responses and the politics around responding to climate change are very different because of that perception of what is driving these changes we're seeing. So I think until at least the vast majority of people are kind of on board with the idea that climate change is the reason for a lot of this, it'll be very difficult to create some sort of comprehensive policy strategy to deal with it. It'll be very much, pushing a boulder uphill.
And Scott, now that you've been president of the company for what, the last 24 or 48 hours, what focus do you see? Anyhow, anything from your perspective, Scott, in terms of how maybe AMI or the private sector is going to be looking at this?
Yeah, well, I mean, obviously, the biggest thing for us is resiliency. And, we've got, we have a team, one of the last teams left in Kabul, that provide healthcare. There's nobody to protect them right now except some of the UN forces. We're in Louisiana, Texas, and Mississippi with some of the ICU units for COVID. And meanwhile, the tropical storms brewing, and we just had Ida roll through without power, trying to do COVID ICU care. It's incredibly, what Ashley was saying, we've grown numb to some of there is no normalcy at the moment. So, making sure we continue to do as much as we can. And it doesn't really matter what causes it. If somebody believes it's climate change or not, the incidents and the events are happening. And certainly they're reported and the news is all over everything. So it's, it's amazing and at some point in time, I literally had to do this. I know it might not be good to shut off all communications, but just to get some, a break from it, I had to shut off the TV at night, talk to my family, shut off all communications for just a little bit, just to regroup. And I think that's part of resiliency. So that's really important to just normalize yourself, to remember what it would be like to not have it all the inputs. It's like Las Vegas Strip. If you're on Las Vegas Strip and all the lights and everything flashing, it's constant. And, it's amazing how you think when you don't have all that, but you forget almost that it still exists.
Great, thank you. I'm going to combine a few of the questions that I got because of time factors right now, and then throw in my own little spin on this as the prelude. And this may end up being, so this is going to be for all three panelists, maximum of 2 minutes each, because we want to close on time. And I'm going to hit you with this and combining several of the questions, but really as my focus has always been, and the students and faculty and staff at the University of Maryland School of Public Health understand, I always say that in public health, you have to be an optimist, right? Because pessimists wash out early. So this is an optimistic hat. And I'm not telling you just to answer it as an optimist, but moving forward, right? In a broad sense, right? We've had these unique experiences in this latest generation, right? The last 2 decades, we commemorate 9/11 and remember. Then we have, other things, the hurricanes, we have Ebola that affected us. We have COVID-19, infectious disease things going on. What have we learned in a broad sense, and what's going to make us better, right? So this is that sense. Dylan, give me a sense, right? Smile and tell me what the crowd needs to know of what we're going to be. Is there something that's good that's going to come out of all these things?
Well, I'm a public policy person, not a public health person. So I was born a pessimist. So.
Okay, next, Ashley.
No, normally I would say, I suppose so it's a great contrast, right? 9/11 versus COVID. There was some level of political unity that came out of 9/11 perhaps for misguided reasons, but you had bipartisan agreement and some level of unity around like what the problem was and how to solve it. COVID, we have, fast forward 20 years later, we're dealing with a problem that's killing as many people that died on 9/11 every day. And we can't agree on what the problem is or what the solution is. And so I would like to say something encouraging, but it's kind of disturbing to me as a policy person who believes very strongly in like giving evidence to leadership so they can make informed decisions. It's difficult when, you know, as Scott mentioned, it's tough for you to disseminate science when there's a underlying distrust in science from a portion of the population, and decision makers in counties and states are perhaps making misguided policy decisions that hurt people. And I don't know that we would be ready for another pandemic or another public health or emergency situation unless the principles at stake were so significant that it caused us to move back together for that opportunity or for that instance.
Great. Ashley, same question.
So I'll give you the optimistic view, and this is what I've learned personally from working with the Red Cross, is that people are kind and people want to help. I mean, every day I'm surrounded by volunteers who come to work at the Red Cross for free. They give their time, they give their expertise, they give their energy, and it's an incredible thing, especially when we're surrounded by so much negativity and so much distrust or disinformation, et cetera. Just understanding that there still are some good people out there that want to help. It's encouraging for me.
Thank you, Ashley. And Scott.
So I'll be in the middle. I'll be the pragmatist and the realist. You know, this is by far, I mean, in my opinion, and Boris, you know, from the very beginning, I've been in all these disasters from the very beginning and literally on site on most of them. And I think COVID by far is the most complex, but I think there's a couple opportunities here and a couple of things that we saw happen that were amazing. The public-private partnerships, I think that should expand as we move forward. You know, the ability for the government to bond with the public and use the wonderful thing we call capitalism in America to make things happen that'll benefit the public. I see that on the for-profit side now. I see that not just domestically, but globally, where, you know, you used to use NGOs and now they're starting to use for-profit in certain situations because it has a better response. It just is better for the people. I think there's an interesting generational thing happening with COVID. And I think it has, you know, I think about the phrase, nobody's too young to lead or too old to learn. And I think that's such a huge piece with how we absorb the information and how we use the younger generation as an opportunity. They're the most fluent in the communication freeway. They know how to get to people. They know how to influence, right? Instagram influencers, right? So I think it's going to be a phenomenal opportunity to educate the younger generation on trust and how to communicate and how to individually filter out the noise that's caused by news, government, you know, whatever it may be, and to really make good, logical, rational decisions. And I think this generation is capable of doing that, but they have to be taught young how to do all that before they're influenced or jaded too much by anything else that we can do. So there are a couple real things that I'm really excited about. And, you know, COVID, because it was so complex, has given us the opportunity to think about some of those things for the future of our country.
Well, that's a perfect way to finish, and I'm glad we had the whole spectrum, you know, in terms of an assessment of that. And you know, as we close this 1 hour session on emergency preparedness and all those different sort of shapes and sizes and forms, I do want to thank the audience for being part of this event and for your excellent questions that were sent in. And to our three panelists, to Ashley and Dylan and Scott, thank you for taking time out and sharing your ideas, your expertise, and your passion with us. And thank you all again to all our organizers here. What I'd like to do at this point is to send off the microphone now to Jennifer Schwartz, who will close our session. I know Jameson just put up the blurb on the chat line about the SPH School of Public Health Alumni Network. And if you're not a member alums out there, please do join us, help support these types of activities, and not only the social aspects of being an alum of our famed school, who, by the way, now is a top 10 school amongst publicly supported schools of public health in the nation, a top 20 in the competition with the private schools as well. So we're doing really well. And it's because of listeners and viewers such as you. Sound like I'm doing a PBS special, but thank you for your support. Jennifer, back to you.
I have a question. was asking the question. Go ahead.
Yeah, is this video going to be posted somewhere?
We have been recording it and should go on the school's YouTube channel.
Sorry?
Okay, so it's going to be on the schools, on the University of Maryland School of Public Health YouTube channel.
Thank you.
Okay, you're welcome. Thank you for being part of this. Jennifer, back to you.
Thank you. I don't have anything else to add. Just look forward to future alumni organized events, and we are glad that you were here with us tonight. It was a fantastic gathering. Great point for our panelists and our moderator. Many thanks to all. Have a good night.
Okay. Be healthy, stay healthy, everyone. So long.